So to answer this question, the main one that comes to my mind is idiopathic intracranial hypertension. This pathology is largely dominated by obese women of childbearing age. It is characterized by headaches, visual loss, and pulsatile tinnitus, and evidence of elevated CSF pressure at lumbar puncture. Most of the time there is a bilateral transverse sinus stenosis with a pressure gradient and at various locations, and the stenting of the stenosis will decrease this gradient and will allow an improvement of the symptoms. As well as this, to a lesser extent, there is also a higher prevalence of intracranial aneurysms and subarachnoidal hemorrhage within female. And the last one is about stroke. In fact, stroke is the third cause of death in women, and it is the fifth one for men. Okay, so evaluation based on gender, I think it's not done properly, because most of the clinical stroke research includes mostly men, and studies were not properly designed to perform sex and gender evaluation. So it can lead to underappreciation of differences between men and women related to presentation, outcomes, and response to treatment. Females are more prone to have atypical presentation of strokes, meaning they will have different accompanying symptoms such as dizziness, headaches, and that might lead to a misdiagnosis of the pathology. So it means that it will delay the initiation of treatment and maybe lead to a worse outcome of the stroke. Yes, there are different outcomes in stroke regarding gender. Women exhibit higher mortality and disability rate with a worse recovery. One of the explanations could be that a stroke happens at a much older age compared to men, and the recovery in older age is more challenging. But the second one could be that women are more likely to be widowed or to be alone and face a lack of support after a stroke. So talking about carotid atherosclerotic disease, there is a difference between men and women. First of all, regarding morphology and composition. Considering imaging, imaging demonstrates difference in morphology of the plaque. Women have a greater rate of stenosis than men. Regarding composition, they have a higher rate of stable, fibrous or fibrocalcic plaque, where men have a higher prevalence of unstable plaque. So this is maybe due to a difference in systemic inflammatory profile. Women's plaque are more prone to surface erosions in opposition of men, for which the typical observation is a rupture. Regarding revascularization, we should stop with the one-size-fits approach, because we should adapt decision-making to gender specificities, and carotid atherosclerosis is a very good example. As a result of these differences, it seems that women require different treatment, and they are at a higher risk of surgical revascularization than men, and they would more benefit from medical management and eventually carotid stenting.